One.
Good evening, and thank you all the organizers for giving me this opportunity to talk on a bit rare but very important topic in today's times, which is metachromatic leukodystrophy. Myself, I'm Dr. Vivek Mundada, and I'm consultant pediatric neurologist. I work in Medcare Women and Children Hospital as well as in Aster DM hospitals in Dubai. So briefly about neurometabolic disorders and what are leukodystrophies. So neurometabolic disorders are a group of genetic disorders, and they're characterized by lack of dysfunction of some essential enzymes or vitamins. And in return, what they cause is affect the development and functioning of the central and peripheral nervous system. And this is often because when you don't have the essential enzyme, there is accumulation of the toxic metabolites. And they are very rare, but have significant burden, especially in the pediatric population. And especially as a part of neurometabolic disorders, there's a big chunk of leukodystrophies, which are metabolic myelin disorders. Leuko is white, and dystrophies, of course, which affect the CNS white matter, and in some cases also the peripheral nervous system. Each type of leukodystrophy, and there are more than 30 characterized leukodystrophies, have specific gene abnormality, and they affect different part of the myelin sheath, leading to range of neurological problems and causing symptoms such as motor function affection or affection of the visual function, hearing, balance, memory, cognition, behavior, and so on. And metachromatic leukodystrophy, although it's rare, is one of the important and commonly seen leukodystrophies in pediatric population, often with a characteristic MRI, because the demyelination, which you can pick up, has a clear pattern recognition if you have a good neuroradiologist in your team. So what is metachromatic leukodystrophy? Leukodystrophies, as I said, are metabolic myelin disorder, and MLD or metabolic leukodystrophy is a rare autosomal recessive. Most of these leukodystrophies are autosomal recessive. And it's classified as lysosomal sphingolipid storage disorder. And it's the most common form of leukodystrophy that we see in pediatric population. The prognosis is fatal, and I'll show you later in the presentation how rapidly this disease progresses. And the patient then progresses to symptoms such as dysphagia, decerebrate state, and eventually mortality is the fate. MLD, the progression is rapid and aggressive in most of the patients. And the whole talk is how to identify early and the significance of catching these people in early in their life. So as I said, it's the most common form of leukodystrophy, and it's due to the deficiency of the enzyme called aryl sulfatase A or URSA. Now this deficiency of URSA enzyme leads to the accumulation of sulfatides in both central nervous as well as the peripheral nervous system. And eventually this now leads to progressive motor and cognitive deterioration and other symptoms like dysphagia, neurological disability, and ultimately death. And it's just the bottom, the flow chart, what happens here. As you can see, because of the lack of URSA enzyme, you get the toxic metabolites, and they're just the histopathological picture to see how they are toxic to the myelin sheath. And 1 in 100 people are carrier on an average, whereas there's 1 in 10,000 chances of carriers of being couple. And that eventually leads to incidence of 1 in 160,000 worldwide. So it's very, very rare. But as I said, among the cluster of leukodystrophies, that's the most common. And how do we classify based on the residual enzyme activity? Because if you don't have any enzyme activity, the symptoms are very early. And usually we get that less than 30 months, and it's called as late infantile. Whereas some residual activity is there, you get the symptoms in late juvenile age, anywhere between 3 years to 6 years. Then there is a late onset because you have more residual enzyme, and these children can present later in the school age or adolescent age between 7 to 16 years, which is called late juvenile. And the milder forms where you can get these in adult onset disease of MLD. And there's just a picture of how classically the MLD can be seen on MRI. As I said, as a part of investigation, if you tend to do MRI and you get that picture, it's more, unless proven otherwise, it's MLD, and you can directly do the genetic test for the confirmation. And this is what has happened in most of my cases when I have diagnosed MLD. So in a nutshell, as I said, it's a rare autosomal recessive disorder due to the lack of ARSA gene, homozygous deletion or duplication or mutation, and the enzyme deficiency is aryl sulfatase A. There's accumulation of sulfatides, and it affects CNS and PNS, and it's rapidly progressive. How do we classify? I've just showed you in detail about when we call early onset and late onset. So early onset is usually less than 7 years. Late onset is more than 7 years. In that, late infantile often presented less than 30 months, and late juvenile is 3 to 6 years or 7 years. Late juvenile and adult. What is interesting, you see the severity and the mortality goes hand in hand. So the middle survival is just 2.7 years in late infantile, whereas the 5 years survival probability is 25.1%, as opposed to 87% in adult. And the mean age of death in late infantile is 4.2 years, and in adult is in early 40s. And this is just the same slide, same thing to expand. But what is interesting, if you see the first sign and symptom in the late infantile group, is the delay or plateau or even regression of the milestone. So children often come with a, let's say, the child has not progressed in terms of development, or if there's a neuroregression, then it's an opportunity to start investigating these children. Whereas in early juvenile phase, when they're school going, the educational and behavioral symptoms are there. They may be affected with the speech impairment, language impairment, some sort of learning difficulty, which is acute onset, and also can be accompanied by the motor symptoms like the gait and motor decline. As opposed to adult onset, if you see, there's the symptoms like dementia, emotional and behavioral problem, which you less often see in the early onset, because the motor symptoms we see more in the late infantile group as compared to the other groups. So in terms of pathophysiology, as I said, sulfatides are a major component of the myelin membrane, and the ARSA gene encodes aryl sulfatase A enzyme, which is a key enzyme involved in breaking down sulfatide. So as a result, if you don't have this enzyme, you get accumulation of sulfatide, and excess sulfatide and deficiency of cerebrosides. This can then lead to abnormal myelin composition or even demyelination, inflammation, and glial and neuronal apoptosis. And as a result of all these processes, there is a progressive motor and cognitive dysfunction as well as death. What happens in terms of clinical course? How do they present and progress? And this is the classical clinical course of MLD. So in the initial phase, there is a normal development. You won't see that unless the child comes or the parents come with a complaint that, there's a delayed development, or there's a plateau, or there's a regression. And this is the phase when the sulfatides have started accumulating in the CNS. Now, there are early signs of symptoms. This is a crucial period when somebody needs to start investigating, because often they land up with, let's say, orthopedician. I've seen many children going to orthopedician, and then they're getting investigation like vitamin D or this X-ray or that X-ray. And we miss that opportunity to catch them early in the pre-symptomatic or even an early symptomatic phase. Because then once the demyelination starts because of the sulfatide accumulation, you see how rapidly there's a neuroregression. So the dotted line on the blue is a trajectory how the child would have developed without it. And the plateau phase is shaded in that pink or red, maroon color area. That's the plateau phase there. And afterwards, there's a rapidly progressing phase where there's a rapid neuroregression, loss of achieved milestones and abilities. So there's a developmental regression, there's a rapid progression within months, and eventually the death is the outcome here. And this is, these are the 4 graphs just to show in terms of the language abilities, which is like expressive language or language decline, and also the gross motor deterioration. And the green graph is of late infantile, and the blue is early juvenile. So the younger children, you see how quickly they deteriorate from that. So, and it is just again the box on the right side also shows in the number. So disease progression is initially slower in these cases in the early juvenile, but potential window is there to treat these children. And after entry into the level 2, which is loss of independent walking, further disease progression is very rapid in both this group, and which you can see in the graph there. As I said, this is one of the diseases which also involves the peripheral nervous system and not just the central. So in terms of the peripheral nervous system involvement, it's a rapid progressive peripheral neuropathy can be seen. And this can be the initial presenting symptom, and which often precedes the CNS symptoms. And atypical presentations are also observed, such as acute polyradicular neuropathy or cranial nerves and caudate vena enhancement. If you do on the scan, and this is just shown on the bottom scan. If you see the MRI image, you can see that enhancement is also there. Peripheral neuropathy is generally refractory to the stem cells. So if you and I'll come to that part in terms of the treatment, and they are refractory. And so the whole essence is early diagnosis and early treatment in these children. We do face a lot of diagnostic challenges in these children, and that is because of the vague presentation. There is no one symptom with which the children can present. It all depends on the affection of the CNS or the peripheral nervous system. And, so for example, like developmental delay or plateauing of the developmental or regression, you can see in n number of conditions. As simple as even hypermobility, we do see that the children walk late, or cerebral palsy, or, there are a lot of big list of these differentials, and that is why there is a diagnostic challenges. Usually what happens in my clinical practice, at least, is MRI is a quicker way rather than ordering the genetic test, or enzyme detection is a bit difficult to get that in the lab. It depends on which setting you're working. But again, the turnover time is a bit late as compared to MRI. So along with the baseline investigation, I often order MRI if I suspect, okay, there's a CNS symptoms alongside the CNS signs alongside the symptoms, then MRI is the best modality to see that. And as I said, if you have a good neuroradiologist, or even if you know the pattern recognition of most of the leukodystrophies in the clinical practice, it gives a good clue to proceed further with the definitive diagnosis. So the MRI usually shows the white matter abnormalities which are consistent with leukodystrophies, and that's how the MLD can be picked up. Believe me, in my clinical practice, all the cases which I have diagnosed MLD are based on the MRI. So I've done the MRI first. We see the pattern, or it looks like MLD. Even the neuroradiologist will agree, and then we move on for the genetic testing. Now, the additional testing which we can perform is the ARSA blood enzyme test. I mean, these days I have moved on directly to the NGS. To do the ARSA, I can tell the genetic lab, can you just sequence the gene and find out the genetic confirmation. Of course, there are other modalities like urinary sulfatide test or nerve conduction studies if the PNS is affected based on the signs and symptoms. And the genetic testing, as I said, is more or less easier access to get. Again, depends on the settings which you practice. And on the right side, if you see, especially the middle image is very classical, because what you see there is the leukodystrophy pattern, which is very classical, what you see in the MLD. So key consideration and process. So typically symptom onset is the trigger event that leads to the diagnosis in patient with no family history. And the symptoms are indicative of disease progression. Then, we have to move to the diagnosis process, and especially the siblings who should be tested in the event of confirmed diagnosis. And also the prenatal and newborn testing should be performed. Now, this part will come in the genetic counseling. Once the child is diagnosed, genetically confirmed, we often refer them for genetic counseling, and the parents are counseled to do this in their next pregnancy, and the siblings are covered as well. And of course, the parents will be covered. So biochemical markers like measurement of the ARSA activity, if it's MLD, it's less than 10%, and urine analysis of sulfatides, molecular analysis to sequence the gene, and the demyelination status, which can be very well picked up on brain MRI, but sometimes you can get this clue on CT scan. But I feel MRI is the better modality. And if you have the peripheral symptoms, then nerve conduction studies, and of course the biopsies in a very rare situation. I personally haven't come across this. And this is mainly to identify the the metachromatic lipid deposits. Why do we emphasize on early diagnosis? I've just shown the graph that earlier the children can be well enough and they progress, deteriorate very rapidly. And one of the key things which we often talk in pediatric practice, where the treatment is available, for example, SMA and DMD, now that we are offering gene therapy, is how early we can treat. Because earlier we treat, better is the outcome. And that's my personal experience as well. We do gene therapy for SMA and DMD in my hospital. And I've seen those who have been treated pre-symptomatically do much, much better. So newborn screening is area of interest in all these conditions. And it's quite critical if we can diagnose these children even pre-symptomatically, because that's the window we need to treat them. It's not currently a standard practice, but which can delay the diagnosis where there is no family history also. And the other kind of the issue there is a high false positive rate is anticipated in terms of newborn screening. Now, measurement of both ARSA enzyme activity and urine sulfatide along with this NGS, which we can do as a newborn screening, can confirm the diagnosis. So if you can see if there's a suspicion, then you have to do all these tests together to confirm the diagnosis. And there are several approaches for newborn screening which are in development, but as I said, as far as I know, no country has taken that approach to do the MLD as a newborn screening part. Now, what are the challenges? As I was just explaining, the vague kind of symptoms they present with. Now, earlier the children can go to GPs or pediatrician, and the early symptoms are very non-specific. So what we need at that area is improving the recognition of early signs and early referral to the neurologist if they suspect that child has a problem. Often they then go to orthopedician or psychiatrist or psychologist or gastroenterologist based on the vague symptoms. And again, the key here is referring them to a correct physician or geneticist or a neurologist. Now, if the neurologist comes across this child or someone who is MLD expert, metabolic expert or geneticist, MRI usually is a key driver. As I said, in clinical practice, we usually do the MRI and then the penny drops, and we end up doing the biochemical as well as genetic investigation there. The symptoms, as I said, when they present, so it's just the comparison of late infantile versus juvenile MLD. So motor symptoms are very common in late infantile phase: hypotonia, weakness, frequent falls, gait disturbances, abnormal movement, or missing milestone, regression of the achieved milestones. Now, these two, which is highlighted in orange, can be the common symptoms within juvenile as well. But what is interesting in the juvenile, the older children, the school age, they get this cognitive decline, speech difficulties, behavioral change, which is so vague that you won't, end up doing MRI very early in the clinical practice. But this is something to highlight. If you have the combination of motor decline and cognitive symptoms which are acute and were not present, then of course MRI will be in the list of your investigation. And there was a good studies. What is the caregiver's perspective? How long did their children get to diagnose, and what were the symptoms? And this is also from their perspective, because they may have the vague terminology to describe. For example, a clonus can be described as twitching or shaking or stroke-like movement, or difficulty of walking can be just unstable walking. Development delay, they can say he was very late to stand up, or he started walking very late as a baby, or stagnation in terms of development can say he could never run freely, he did never achieve that. So it's like a persistent child, a persistent toddler. So we have to be very cautious in what to take up from the history as well. And if you see, the first medical consult is often delayed, and that is because the primary physician or the GP may not refer directly to the neurologist when they see these children with a vague symptom, unless there is a prominent spasticity or the CNS signs are there. And this is due to the insidious nature of the initial symptoms. They're very slow to progress as compared to the rapid neuroregression. And that's why many reported delays are reported there. So the time of symptom onset to the first medical consult is around 5.1 weeks, and the range was 1 to 24 weeks to the first visit. And briefly, in the end, I'm just touching base on the new treatment areas and the reason why we need to treat these children early. Now, traditionally, what was available till now is a hematopoietic stem cell treatment, which is not indicated in the late infantile form, but in the juvenile form, yes, because the older children, it's only used in minority of the juvenile patients, and it has limited efficacy. It can be associated with acceleration of disease progression. And if treated early, it can result in the short-term disease stabilization. So it's not a very promising treatment, but that was the only treatment available till now. As in addition to the other MDT approach, in terms of the pain and end of life and disease-related morbidities and symptom management and the palliative approach. So stem cell was the only available treatment. But then we have now FDA approval for the genetic gene therapy, ex vivo gene therapy, what we call it as. And this was recently approved in US as well. The FDA approved just in March this year. Europe, it has been available as LibMLD. And now in US also it's available from March 2024. And how does it affect? I told it's ex vivo. So what happens is the cells are collected from patient's bone marrow. The blood stem cells are selected and purified. A working copy of the gene is inserted into these cells. And these cells are again, the patient is conditioned to receive these cells, which is now called LibMLD. The gene-corrected cells are infused back into the patient, and the cells engraft and start to proliferate. And this is how the gene therapy is done, as opposed to in vivo therapy, just like for DMD and SMA we do. This is a bit tedious process, and that's why very selective centers do that in the world at the moment. But it's a ray of hope. But the point to note, as it is only indicated in the late infantile or early juvenile form without clinical manifestation, because once the child loses ambulation, we miss that opportunity to treat with the gene therapy. So they should be able to walk independently, which means the patient's GMFC MLD score should be less than 1. And the cognition also should be intact. Their IQ should be more than 85. So if you see, we have very narrow window of opportunity to treat this patient. And that is why the early diagnosis is very important, because once they start regressing, they even lose this hope of receiving the gene therapy. And this is just to highlight the disease as a whole, how it presents, and how to diagnose and the current treatment approach for MLD. So that's all from my side. If you have any query, this is the last slide for LibMLD, just to show some studies there. If I can quickly show you, the survival rate is 100% as opposed to the natural history of MLD, which is just 36.8%. And on the left side, if you see, the first graph is the LibMLD, the gene therapy, as opposed to natural therapy. The pre-symptomatic patients in year 2 and year 3. So I won't go in details in the number, but of course the survival rate itself can tell how significant the changes this patient can achieve. And for any contact, you can contact Genpharm. Thank you very much. Thank you.